Being a surgical resident or a surgical intern, have you wondered why that wound is not getting better despite doing everything? I have done everything. I am giving the proper antibiotic according to the culture report. BSR is in controlled range, but still the wound and the patient is not improving and the wound is still infected and heavily exudative. Why does that happen? Wound care is a very detailed topic and a proper wound care requires holistic approach. Being junior doctor or a surgical intern, we are not aware of wound care products. Even if we are aware of some products or wound dressings, we are still confused about which one to select for a particular wound. At the end of this presentation, you will have sound knowledge regarding wound care products and wound dressings that are available in the market, and you will confidently manage your patients and the wounds in both public and private setup. Hello everyone, my name is Dr. Talha and I have presented this very presentation at multiple forums and it will prove very beneficial for you as well. Let's start with a clinical scenario. Mr. Junaid, a 45 years old male, is a diabetic for 10 years, non-compliant with his medication, presented to your OPD with infected wound on his leg. You opened the dressing and every other doctor in the OPD was looking at the wound due to foul smell. On examination, thick exudative discharge was present. Peripheral pulses were intact. Sensations were decreased over the affected limb. The wound bed was covered in 75% slough and 25% of pale granulation tissue. How will you proceed further with this patient? Explain with holistic approach. I hope most of you are thinking that it is an infected diabetic foot ulcer that needs surgical debridement along with glycemic control and antibiotics according to the culture report. But which dressing should be used after surgical debridement? Will a simple saline soaked dressing help this patient, or we need some other type of dressing? To understand wound dressings, we need to understand wound healing first. On your screen, you can see common types of wounds that are encountered on a surgical floor. And here is how the wound bed behaves: becoming reddish or pink when it's healing, or yellowish in exudative phase, and if it is too late and necrosis have occurred, it will turn black, indicating the dead tissue. So to promote healing, we need to convert a yellowish wound that is exudative into an epithelializing or healing wound. And this wound bed preparation follows the time principle as you can see on your screens. This is a very important table and I suggest you to take screenshot. If the tissue is not viable or any slough is present, remove that tissue with surgical debridement until viable, well vascularized wound bed is encountered. If there is any active infection or inflammation, first remove the source of infection with active debridement and give antimicrobials. It's better to use antimicrobials according to the culture report. Heavy exudate or foul smell is indicative of infection. M in the time principle is for moisture imbalance, and this is the point where wound care products comes in handy as they help to restore the moisture balance. E represents the outcome of T, I and M. It shows whether the edges of wound are advancing or not. If this does not happen in 2 to 4 weeks, then T, I and M should be readdressed or referral to a specialist care should be made. Now that we have understood the time principle, let's discuss the purpose of a wound dressing. As you can see on your screens, the dressing not only covers the wound, but it promotes healing, prevents infection and mechanical trauma to the wound. It absorbs the exudate and prevents further contamination. So the primary goal is to promote healing without further infection. This slide here shows the characteristics of an ideal dressing. It should allow gaseous exchange between wound and the outside environment. It should manage exudate and maintain hemostasis. It should not cause allergy, and last but not the least, it should be cost effective. And this point here is the most important point, as many dressings available are quite expensive. These dressings are usually categorized into passive, interactive and occlusive dressings. Passive dressing simply cover the wound and prevent the wound from dehydration. As the name indicates, it is for healing wounds that are of low exudative type. You can see its types, and its main disadvantage is that it needs to be changed twice or thrice a day due to these issues. Interactive dressings actively interact with the wound by providing optimal environment for healing. It has many types. Occlusive dressings, as their name indicate, seal off the wound from external environment, and most of the interactive dressings are occlusive in nature. Films, foams and hydrocolloids are its main types. Now let's have a detailed discussion about these wound care products. Alginates, they promote debridement and granulation and absorbs the exudate 20 times of their own weight. They are biodegradable and they can be easily irrigated with normal saline for their removal. It can be applied to a wet and a cavity wound. Alginates are available in the market with the name of Caltostat. Film dressings are impermeable to fluids but still allows gaseous exchange. They are non-absorbent and can be used as both primary and secondary dressing. Being transparent, they allow the direct visualization of the wound and promote healing by keeping the moisture in check. Tegaderm film is one of the common examples. Foam dressings provide thermal insulation but still they are permeable to gas. They can be removed easily. Sunniplast, that is very commonly used in our country, is a type of foam dressing. They are available as polyurethane and silicone. You can see the examples on your screen. Hydrocolloids are occlusive type of dressing and have gel forming properties. These dressings contain fluid that is changed into a gel with absorption of exudate. They promote autolytic debridement. They not only protect the wound but they also provide pain relief. The most important feature is that they should be removed after 72 hours. Before that, if you try to remove them, they will cause trauma to the wound bed. Deoderm or Tegaderm are available hydrocolloid dressings. Deoderm patches are usually used for pressure sore ulcers. Hydrogels, as their name indicates, contain more than 90% of the water, promoting debridement of a scar and the slough. These sheets also reduce pain, but they require a secondary dressing. Hydrofibers are just like alginates and they work on the same principle, but they are not alginates. They are easily removable in one piece. They also aid autolytic debridement and locks in the bacteria and the exudate. Non-adherent dressings are used for lightly exudative wounds that are granulating. Examples include Atraman, which is impregnated with triglycerides, and Mapital, which is a soft silicone contact layer for sensitive skin. Antimicrobial dressings are very important for infected wounds or for the wounds that are on high risk of infection. For example, a healing diabetic foot ulcer. Inadine dressings or povidone gel is available freely. Silver dressings are also available for the use in burn patients. PHMB dressings contain betadine, which penetrates and removes bacteria. Algivon is a honey impregnated alginate. It facilitates debridement and it has a documented role in diabetic foot ulceration. EUSOL is another antiseptic used for dressing. You might have used it in theaters. It also promotes autolytic debridement. Hydrogen peroxide is also a topical antiseptic and it kills pathogens with oxidation burst. So these were the basic wound care products available in the market. With advancement in medical science, these dressings are getting better with every passing day. But the main concern is their availability and their cost. Other adjunct therapies for wound healings are pressure therapies, as you can see on your screen. There are some other advanced therapies as well, but they are not readily available, especially in the developing world like the one we live in. So this was too much of knowledge, right? And you don't remember anything. It's okay, don't worry. This table here summarizes the whole presentation. If the wound is necrotic, use hydrogels for dry necrosis and non-adherent dressings with surgical debridement of infected wound or a wet wound. For exudative wounds, remove the slough until you encounter the healthy wound base. Use hydrogels or foam dressings for low exudative wounds. For high exudative wounds, you can use Hydrofibers, foam dressings, or you can prefer alginates. For infected wounds, along with holistic approach, you need topical antimicrobial dressings. Foam dressings help with granulating wounds. For epithelializing wounds, hydrocolloids and film dressings are helpful. So this concludes our presentation. These were the basic wound care products that are available in market. These products are also available in developing worlds, but they are quite expensive. I hope this presentation helped you. Share it with your colleagues that are working on a surgical floor. Thank you for your patience.